Welcome to Cancer Explained with Central Care Cancer Center. It's likely that someone you know has been diagnosed with a form of cancer. Learn more about specific cancers, their risks, signs, symptoms, and treatment options by listening to Cancer Explained.
Hello and welcome to Cancer Explained with Central Care Cancer Center. My name is Leanne Powers. I'm the Marketing Director for Central Care, and with me today is President of Central Care and Radiation Oncologist, Dr. Perez-Tamayo. At Central Care Cancer Center, we are dedicated to keeping expert cancer care close to home. We have independent state-of-the-art facilities throughout rural Kansas and in Missouri. Whether you need radiation or chemotherapy, a second opinion, maybe access to clinical trials, financial counseling, or other supportive services for yourself or your family, even genetic screenings for cancers, Central Care is here for you. At any time, feel free to email with any questions or comments. AskDoctor@cccancer.com. That's AskDoctor@cccancer.com. Well, March is National Colorectal Cancer Awareness Month, so today we're going to be discussing colorectal cancer as well as anal cancer. First off, as we often do, if you don't mind, Doctor, let's talk a little bit maybe about anatomy of the colon and rectum and where they sit in the body.
Well, thank you very much, Leanne, for having me here. There's quite a lot to talk about that because certainly the way of treating each of these cancers is unique to their anatomical position. First of all, even though the anus is part of the colorectal, the end of the colorectal family of cancers, it is unique because it is really outside the body in the dermis or the skin, which therefore means that the cancers of the anus are primarily a type of skin cancer. But they do not behave like skin cancers. They are quite aggressive, and they go to different lymph nodes, and when they are stage 4, meaning they have spread through the system, they go to different parts of the body based on their anatomical position. And what you need to understand with everything that is cancer is the systemic spread, wherever it is, whether it's lung cancer, colon cancer, breast cancer, is related to where and how that organ is fed by the veins and arteries. So the veins and arteries of the anal area will be called the hemorrhoidal system. The hemorrhoidal system is composed of two types of the superior and inferior hemorrhoidal system, which one goes directly to the liver, the other one goes directly to the lung. And in addition, the groin nodes, basically where your groin is the first lymph node group to be involved if you have anal cancer. So these cancers are treated very differently. They are actually very curable, even in a little bit later stage, like with lymph nodes. But once they get into the system, meaning they're metastatic to the liver, the lung, they're always usually fatal within a year. So you want to get them early. They have symptoms early because they are very painful. If you've ever had a hemorrhoid, you know what that is like. You feel very uncomfortable. You cannot sit. Things bother you. When you wipe, you may get blood. It doesn't stretch well because when you have something there, that imagine a large wart in your anal area. Well, the sphincter then does not have the elasticity, and so it starts cracking, and so it starts bleeding, and it's very, very painful. And here, you have no idea how many patients I have where they have gone to their doctor, and the doctor sees their region down below, and they think it's a hemorrhoid. But the patient knows that it's not a hemorrhoid. They know because it doesn't feel like a hemorrhoid. It feels more. The pain is tremendous. And so they need to go to a surgeon, okay? The type of workup for the anal cancer consists of an analoscopy, not a colonoscopy, an analoscopy, which is a very specific type of scoping. So the surgeon would know what to do, and they would need to look at it in that manner. And then they would diagnose it, and from there the workup begins.
As far as, and when you talk about colon cancer and anal cancer, so if you have polyps of such within the colon, that would spread as well to the?
Well, no. Actually, it's a completely separate area. The colon cancers, whether they're rectal or the other parts of the large bowel are adenocarcinomas, not skin cancers like squamous cell carcinomas. They're actually of the lining of the colon, and they behave very differently. Again, with the same mentality that they will go to the regions where the blood supplies that part of the colon. And their anatomy of the lymph nodes is also very unique. That's why we divide the colorectal areas. That's why it's not colon cancer, because the rectum is part of the colon, but they say colorectal because the rectum is outside the bag or the coelomic cavity, the peritoneum, that holds the rest of your gut. So if you can imagine your small bowel, your large bowel, it's enveloped in this baggie like a balloon, but the rectum is outside that balloon. So it is, again, treated in a different way. And it doesn't spread inside the bag usually because it is not in the bag. It's outside the bag. And it's treated depending on how close it is to the anus. If it's very close to the anus, if your cancer is close to the anus, you cannot spare the anal sphincter, so you will need to have a bag. If you are out a little bit further up from the anus, you may be able to have a specialist do a type of surgery where you can actually reconnect your sphincter to the remaining colon and avoid having a colostomy or a bag.
So cancer polyps, that colon is long. It's the large intestine. I mean, it's
very, very long, and polyps are different than the warts that could be from the anal cancer. They are actually growths. They can be flat like a wart, or they can be polyp. That's what it means. It means a hanging like a candelabra, let's say, but it's hanging, and it can be a benign polyp, meaning something that just was irritating that area, and it started to form like a bunch of grapes, let's say, and they can't grow very large and become obstructive, but they can be benign. But some polyps will become atypical or abnormal, and they can be very small or they can be very large, and the colonoscopy can visualize it and cut them out. And if they're not invading lower down in the lining, then that's all you need, and you can avoid having cancer altogether.
How long does it take usually these polyps to develop?
Well, they can develop very, very slowly. In fact, if they're grade 1, and grade 1 here doesn't mean stage, doesn't mean how big they are, it means how slow they are. Or they can be grade 3, which can be rather fast, but nonetheless, it takes a good year to grow a big polyp.
And does the location of maybe where that polyp or that might be a tumor in that colon, does that matter where it's at?
It does, because when there's a lot of room, like the cecum, which is the end part of the large bowel, where basically the small bowel connects to the large bowel, it's a bag. Imagine like a purse. So you can have a whole lot of things growing there and you wouldn't know it. So it's like a hobo purse, actually. You can lose your keys there for years. So yes. Now, as you're getting down to the rectum or like the sigmoid area, it is narrower, and other things are pressing on it. There's other structures that are pressing, and therefore you may have symptoms. And then the flexures are these like elbows, like if you go up the colon and then it goes to the transverse colon, there's a little elbow, like imagine a plumbing. There's an elbow there by the spleen, and then as you go to the transverse colon, there's an elbow that goes down in the hepatic flexure where the liver is. So those little elbows, imagine the plumbing areas, they can get clogged easily because they are twists.
Yeah.
So yes, you can have symptoms earlier in those types of places.
So the American Cancer Society says overall, the lifetime risk of developing colorectal cancer is about 1 in 23 for men and 1 in 25 for women. So definitely, it's not just one gender kind of cancer that can occur.
That's right, and it's the third most common cause of death, cancer-related death in the country. There are some groups that are much higher. If you have a familial predisposition for cancer of the colon, and there are some insinuations that certain exposures to food and not eating roughage can put you at a higher risk.
Again, I am with radiation oncologist and president of Central Care Cancer Center, Dr. Perez-Tamayo. Well, March is National Colorectal Cancer Awareness Month, so we've been talking about colorectal cancer. And so, doctor, when it comes to those risk factors, I assume there's some family history, and you had mentioned maybe some foods as well that you can eat, maybe even having inflammatory bowel disease. Is that even a risk factor?
There have been many papers written on all kinds of risks that may or may not be true. There is, some inference that anything that has nitrites, like the hams, for instance, or there's the lovely charred rib ends, anything that has more carbon in the meat, in fact, higher, just even eating a lot more meat is giving you a higher risk. And I don't know if it is because you're not eating as much roughage or it is the meat itself. Some people with a slower bowel, there's some people that have just a lower motility, meaning that the bowel just goes slower. They're constantly constipated. So food stays in their bowel longer and may cause some toxicity because they don't have that clearance as somebody that has a more rapid. Yet at the same time, ulcerative colitis and other inflammatory diseases of the bowel or autoimmune diseases may give you, maybe you're just fighting too many wars at one time. There's the Lynch syndrome and other syndromes that are genetic, which can be also, you are going to be more likely to have a cancer. There's something called microsatellite instability that can give you a chance for cancer of the colon. And so the number one, whether this is true or not in your family, prevention is the best thing to avoid having a cancer that becomes infiltrating and causes you to have a lot of problems and perhaps even death. So this is something to be aware of, and people that don't eat enough fiber.
So I need to get my corn checks in or my Wheaties or something, right?
No, more like fresh vegetables and fruits.
What is it that my grandpa always ate that was high in fiber? It was the shredded wheat, I think it was. No, you're
That's
talking. Thank you, doctor. As far as those symptoms go, I assume the number one is blood in your stool, or
well, blood in the stool is often seen, which is either bright red blood when it's something in the rectum or the anus, of course, or it could be dark blood, which is something in the upper bowel. But it could be your gastric, it could be your stomach as well. But digested blood is black. So if you have black tarry stools, and tarry means it's just like tar. It's kind of like it has kind of a stringy feel to it, and it's black. You should be very concerned, and it is you need to see the doctor, not only because you can have cancer, but you can bleed to death. I have seen people bleed to death because this cancer can make a hole in where you have a lot of vessels, and you can die not from the cancer, but from the basically exsanguination or death from just losing your blood. So the symptoms are that, and then people also have, and as it becomes more advanced, you have this change in bowel habits. Let's say you were very regular, you had bowel movements in the morning, then all of a sudden you start being constipated, and then you have diarrhea. And what this means, people don't understand what is behind this change. What is behind this change is you have something that is clogging your bowels from, going out. And so stool starts to accumulate behind this clog. And then all of a sudden, the only thing that comes out is this water or whatever is loose. So you get this diarrhea, but you really don't have a good bowel movement. You're having the streaming of the part of the stool that is water. And then maybe through all the pressure that this clogged up stool causes, you have this a huge bowel movement with pain usually, and you may feel relief because all of a sudden you have all of this bloating from the stool not being able to come out, and then you start the cycle again. But a very really undescribed symptom that is very, very common, and I think this is probably the number one symptom, and probably the first symptom, is that you start becoming tired. Very much years could be becoming tired and more tired, and that's because every single day you start losing blood that you may not see. It might be microscopic. It's before you see the tarry black stools or before you see the bright red stools, but you're seeing within your stool is drops of blood, and you slowly are becoming anemic. So if you go to your general doctor and they start seeing you have anemia, you need to be worked up, because this is probably the reason why you have anemia.
And that's why they say, let's get some blood from you and see what's going on, right? Check those red blood cell counts for sure. So many of the symptoms I know that you just listed there, which fatigue, it just seems to be, I'm had a long week at work, and I'm just tired. But it is a sign for several cancers, honestly, that, maybe you should give yourself some rest, but then also get yourself checked out.
If it's out of proportion, and it's not right, and be persistent. You are your advocate, and you have a choice. If you are not satisfied with the answer, seek another, because it's your life. You need to be your own steward.
So when it comes to the stages of colorectal cancer, of course, we've always say too, prevention is key. So if you get your colonoscopy and get that screening done ahead of time, your prevention is much higher, as far as finding what was wrong, the tumor or such, having, the treatments and getting rid of it. So the stages, I'm sure your survival rate varies from stage 1 through stage 4, right?
Oh, absolutely. In stage 1, and you can even be a pre-stage or an in situ stage where it's 100% survival, meaning when you have your colonoscopy, you have a polyp that has some atypia or in situ cancer, you take it off 100%. However, when it starts getting into your lymph nodes or it starts getting through the bowel wall, your stage 3 cancer, you're no longer, you're curable, but it's only 40%. Basically, you've dropped your curability from 100% to 40%. It doesn't mean you're not going to live maybe 5 years with the cancer of the colon. In fact, most patients that have stage 3 cancer will survive 5 years or even more, but they will survive with a lot of difficulty. So this is the problem. You will die. Most people die with stage 3 cancer. 60% will die. But the 40%, the 60% that actually do die, that don't die, the 40% that don't die, will survive in a way that is not really in the optimal, way. You're not going to feel well. You're going to have all kinds of symptoms if it goes to the brain, if this cancer goes to the lung, if it goes to the liver. So you're constantly fighting this cancer in other parts of your body. You're surviving, but is that life, it's not optimal. So you don't want to go there if you can avoid it. And most people can if they just can go and get checked.
So the lymph nodes is where this cancer will spread into those other organs, the brain, the lung, liver?
No, the lymph nodes are local, meaning they will be around the colon. There's a fatty part of the colon, around the colon, and they have lymph nodes, and it can go into if you imagine a bouquet of roses, that bouquet or the root of the bouquet is where eventually all the lymph nodes end up. But there's also vessels, and the vessels are the ones that take it to the blood, into the liver, the lung, the brain, the bone, and other parts, the adrenal glands. And so when it starts going into the blood and starts being stage 4, then you are fighting different parts besides your colon that may not be controlled locally. You may be fighting liver pain, because when the liver has involvement, it stretches its capsule. The liver has a capsule, and that's very painful. If you have metastatic disease to the brain, then you get a stroke. If you have metastatic disease to the lung, then you have bleeding, or you have insufficient air. So you begin to have all these symptoms that you could have avoided.
Again, I'm with radiation oncologist and president of Central Care, Dr. Perez-Tamayo, and March is National Colorectal Cancer Awareness Month, so we have been highlighting colorectal cancer on today's program. When it comes to screening and treatment options for colorectal cancer, doctor, of course, the colonoscopy, and they have lowered the age. At one time, it's like when you turn 50, get your colonoscopy, but they have lowered it to 45 now as when you should start getting your colonoscopy.
That's right, and even lower if you have genetic risk.
Right, exactly. So I know people don't seem to, when you mention the word colonoscopy, of course, the vision probably pops into their head. But I mean, at the same time, the importance of catching those polyps is so important and so vital. And that's essentially what you do. I mean, the scope goes up. It can, the doctor can kind of see where the polyps are and able to, I want to say, snip the polyps, if that's correct.
It is almost a snip. And the thing about it, people don't be scared. It actually is very simple. It's done under what they call conscious sedation. So you really are not completely anesthetized. In fact, they may even talk to you. You may not remember what was said, but it's like you're sleeping a very nice, relaxing sleep. In fact, the worst part of the whole thing is when they start to wake you up and you don't really want to be woken up. So really, that's just the worst part of the whole colonoscopy. Yes, you do have to have a prep, which not many people enjoy, but it's these days it's simpler, and if you follow the instructions, it's easy enough. The colonoscopy will take just really not a long time, maybe 20 minutes, and then if there's something to be done, they do it. If there is a diagnostic, let's say there is a colon cancer there, and they will just do a biopsy, because the treatment now is usually, depending on where it is, it's usually not surgery up front, although sometimes it is. So sometimes, depending on the stage, it may require a neoadjuvant approach. Neo means new, adjuvant meaning supportive. So you may have a neoadjuvant approach with chemotherapy or immunologics, and then also or not radiation, depending on where this is. And I'm just talking about colon cancer. Anal cancer and rectal cancer are treated differently.
When it comes to a word that I've heard a lot of times used, or the term doing a tumor marker or doing a tumor marker test of such, but that's after you've been diagnosed with cancer. Is that correct?
That's right. But, people put a lot of emphasis in it. Tumor markers are something that the tumor basically sheds or secretes. But some tumors don't secrete that. In fact, the more aggressive the cancer is, the less it will do that. Because to be able to produce a tumor marker, it means that the cancer has enough differentiation, meaning it is organized enough to produce a certain type of, we'll say, juice in your circulation, and then you can follow it when you get treated to see that you're responding. When a tumor is so monstrous and wild, it doesn't even know, it doesn't have the organization. It only wants to grow. It will not produce anything. You will not be able to follow it through the bloodstream. Is it good that you have a marker? Well, it's good in that you can follow it. It doesn't really do anything else for you.
What are the possibilities then of colon cancer coming back? If you've already had it and polyps removed, surgery, treatment, then the polyps come back?
Well, that's why if you have a polyp that is either malignant or pre-malignant, that's why you have to go more often to get them removed, because the chances that entire colon can go bad on you is always there. So yes, you can have a new primary, or you can have a recurrence if they remove it, and maybe in the anastomosis, meaning where they put you together, you can have a recurrence. So you always need to be monitored.
Jumping now to anal cancer just a little bit, as far as risk factors go, is HPV, would that be a risk factor for anal cancer as well?
It's almost 100%.
Is that
HPV,
right?
HPV, yes. HPV is the most common reason. In fact, 99% of why anal cancers exist. It is a human papillomavirus basically promoted cancer. If you get the vaccinations, you will absolutely decrease that to the lowest level. It's not 100% reduced, because there's like 30 HPV possibilities for cancer, but you will remove most of them. But again, if it's early enough, you can get rid of it. It is not an easy course because if you can imagine that area, it's very busy. You sweat, you sit, you have bowel movements. So that area is going to give you a lot of symptoms when we're treating it as the cancer sloughs off. So imagine having something that leaves you a raw area and then you're stretching it to have a bowel movement. It is not easy, but it's curable. And the treatment is not forever, and it's highly, highly curable. So even though it is, again, something that is hard to get through, you know that once you get through it, it will be a good outcome and highly curable again.
As far as the cases go, is it mainly an older adult kind of?
No, not at all.
Okay.
Not at all. It's it can certainly be in an older adult, but actually, the range can be actually younger, but usually I would say about in the 50s and 60s is the number one where you see it the most.
How could you screen for anal cancer, or is it mainly just a digital kind of?
Well, you can't screen for it, but when you have a pelvic exam for women, and when you have a rectal exam for men, you can see it or you can feel it because it feels gritty, and you can actually be your own examiner. If you're cleaning yourself and you have a bowel movement and you have, you feel that you're not cleaning yourself well, you still have stool, take a little bit of Vaseline or take a little bit of even Preparation H and just feel your anal area. And if you feel like there's a wart, because it feels just like a wart, it's kind of gritty, almost like a callus, that is cancer. So you go and tell someone about it to be able to get rid of it.
Now, in my head, I'm thinking, it just probably is a hemorrhoid.
Well, it can feel like a hemorrhoid, but it's not soft. A hemorrhoid feels soft. This is not soft. Okay. This feels gritty like a callus of your foot.
So in talking about all of this, I mean, it's very sensitive. I mean, people probably don't want to have this kind of a conversation even with a spouse or something about how, they're checking themselves or trying to feel themselves, or even what anal cancer or colorectal cancer is all about. But speak to how important it is to have our bilingual physicians and staff at each of our clinics, because especially those that, necessarily maybe not understand in English what's being said to them.
This is very complicated, even for people that understand you, in your own language. And there's always questions that you need to answer, the side effects, the risks, also the whole treatment process, and when is it going to start. When people hear cancer, it's like they put some kind of, earplugs immediately, and you start not understanding anything. The families are important to be there because they can be kind of your, advocates, and they can also hear and have opinions. I have often the case where you have three people hearing the same thing and they have three different, interpretations of what you said. Now imagine if you speak another language, let's say Spanish, and you're describing everything in English, and even if there's a translator, translation gets lost because it's all medical terminology. So in Central Care, we have bilingual doctors, we have bilingual nurses, and it is very, very nice to hear it in the language that you will understand and be able to ask the questions. This is a hard topic, and it's one that many people have a hard time even talking about it. It's private. Many people feel ashamed for reasons that I don't understand, but they do. And getting people comfortable is part of the battle. Having themselves understand that nobody's judging them, nobody is, that this is something that happens, and that, to get rid of it and have a self-sufficient life for whatever life you have left is the main aim. So, and that is important, because survival is one thing, but surviving well is another.
And I have to also just reflect on my father, God rest his soul. Farmer, and he, was one that was very staunch about going to the doctor. And I know people listening might feel the same way too, where they don't necessarily, it's nothing, it'll pass. But no, it might be something. And, no matter what generation you are or what your occupation is, just like you said, we understand it's a private topic, but at the same time, your benefit of getting it checked out and screened is so much better than not, because like you said, you don't want to maybe survive the treatment so far, but you might be stuck with a colostomy bag or something,
Exactly. And not only that, but may you survive 5 years, but then it goes to your liver. You're surviving just to get the side effects of systemic disease. But you know what I find, Leanne, and I see this more often now, is that the people do go to the doctors, and for some reason, they still feel that it wasn't, they just didn't get the right answer, or they feel that there's something more, but they stop there. They say, okay, I've done my duty, and now, I'm comfortable. If you think that there's still something unanswered, get it checked again. So second opinions are always welcome.
Thank you so much, Dr. Perez-Tamayo. We appreciate you taking the time to listen to Cancer Explained with Central Care Cancer Center. With independent facilities throughout rural Kansas and in Missouri, Central Care offers complete cancer care all under one roof, so there's no need to travel far for the best care. Whether you need radiation or chemotherapy, maybe a second opinion, access to clinical trials, financial counseling, or even supportive services for yourself or your family, Central Care is here for you. You have a choice. Bringing that expert care to you is an important component in the success of your outcome. Being surrounded by your family, your friends, that can be the factor that elevates your treatment. Feel free to reach out to our offices calling 800-592-5110, or you can visit us online, cccancer.com. For Dr. Perez-Tamayo and all of our amazing providers and nurses, I'm Leanne Powers. Thank you for listening to Cancer Explained with Central Care Cancer Center.
You've been listening to Cancer Explained with Central Care Cancer Center, offering expert cancer care that's close to home. Central Care Cancer Center has clinics throughout Kansas and in Missouri. Central Care Cancer Center, online, cccancer.com.